Okay, it is 9:01. This morning, I would like to go ahead and call the Health and Hospital Committee meeting to order. My name is Otto Lee. I'm the chair for this committee, and along with my vice chair supervisor, Margaret Abekoga, with both supervisors present, we do have a quorum. Item number 2 is for public comment, not on addressing item that's not on this agenda. So any public would like to speak, this is time to turn your cards or raise your hands on Zoom. Do we have anybody?
We do have 2 requests to speak online.
Okay.
Next speaker is Kenneth Horowitz. You will have
Okay, let's do two speakers, so 3 good.
two speakers.
Okay, 3 minutes each. Go ahead.
All right.
Yes.
Ken Horowitz, you will have 3 minutes to speak. Timer will start when you begin speaking.
Good morning, committee. This is Dr. Ken Horowitz from your Health Advisory Commission. And I would like to ask you for your next meeting, the opportunity for our Health Advisory Commission to give you again the opportunity to discuss functional integrative medicine. I know Supervisor Abakova is new to this committee, and we wish to revisit some of the points that we raised a number of years ago on integrative functional medicine. My second point is there was a recent off-agenda report from Santa Clara Valley Healthcare that little progress has been made in the last number of years since we brought this to their attention. And in fact, there was a comment that they were continuing to evaluate, but they would bring this up in the future sometime in 2025. Our commission feels that this progress has been very slowed, and they would like to see more action currently. And given the financial uncertainties, we think this is a great opportunity to start thinking differently and to begin a pilot program in primary care clinics so we can bring together integrative and functional medicine such as acupuncture, nutrition, spirituality, among other things, to the clinics. And as mentioned, Santa Clara Valley Healthcare is committed to providing quality care that provides the right care at the right time, meeting the patient's needs. And we feel that these other integrative practices would address that. And we don't have to duplicate or we don't have to start anything new. There are plenty of programs out there at PAMF, Hennepin System Hospital, which is a similar hospital system as we have in Santa Clara County, are currently doing these things. And so this is not going to involve a lot of money. In fact, no money at all. It's just about what we might call right sizing. And I'll be talking about right sizing when we get to agenda number 9, and I'll have the opportunity to talk to you about some of the proposals that are being brought forward in the proposed budget. Thank you for your time.
Next speaker is Sandra Asher. You will have 3 minutes to speak. Timer will start when you begin speaking.
Good morning, everyone. I'm Sandra Asher. I'm a member of the San Jose Trust Community Advisory Board, or CAB, and also a member of SURGE Santa Clara County. And I'm here because, first of all, I wanted to thank the county for highlighting trust as the primary emergency mental health crisis response program in the budget recommendations, along with the dissolution of PERT. But I'm here because I'm really concerned about some proposed changes to the Trust Community Advisory Board structure. While the behavioral health departments plan to consolidate the regional CABs, yeah, I can see how that would drive consistent messaging. I'm really apprehensive that the community's voice will be diluted down because they're reducing the number of representatives to only 3 per service area. And in addition to that, there's no guarantee that the impacted family members who originally collaborated with the county on the design of trust will be selected for the new CAB. And I'm not sure if you're aware, but in the original MHOAC application, the CAB structure was an integral part of the design. It was intended to be an ongoing partnership, really, between the community stakeholders and the county and the providers, and a vital feedback mechanism, prioritizing those with lived experience. So it's really what's core to differentiating trust from other crisis response programs and an integral part of that innovation grant application. So I urge the supervisors to step in and ensure that community voice is not weakened and that our impacted family members are guaranteed to continue as part of the Community Advisory Board. Thanks.
And that concludes our request to speak.
Thank you, Clerk. So we move to item number 3, which is the approval of the consent calendar and changes to the committee agenda. So before we start, I would just like to ask if I would like to add item 9 onto the consent calendar, if you have no objection, Vice Chair.
Yes, that's fine.
That's fine. And then the other one is, although we still have yet to see the final set of, recommended budget recommendation to be published later this week, I know there have been some concerns about the EMS raising the fees through the hospital designation fees and dispatch fees. And so this leads me to my other request, which is to defer item number 14 to the May budget workshop to have a full board discussion on the concerns raised by partnering hospitals and cities about EMS raising hospital designation fees and dispatch fees respectively, and not increasing the fees gradually over time, but instead such a quick instance at the same time. One concern that was raised, I think Kaiser and Clara and Chris Merriman have some proposed fees from, which like if over 5 times increase, so it's very significant. So I just want to ask, and that's okay with Vice Chair. Yes, James, go ahead.
We'd be very happy. I think it makes sense to take that up. That's a budget-related proposal, and we can walk through the rationale at that time with the full board for why we believe that's a very reasonable proposal. We can show some data on that, so I think it makes sense to bring that forward at that time.
Good, all right. Let's see if I've opened up the public. Oh, sorry.
Oh.
Do you have any other changes to the consent calendar? Sorry.
So just to clarify,
Yes.
you would like to table 14 to the next meeting? Is that
Yeah,
so we
actually,
could have
defer
a
all the way
full-
to the budget workshop, yeah.
Oh, the budget workshop. Oh,
Yeah,
okay.
May budget workshop for item 14.
Okay, yes. I would appreciate a chance to have a full discussion. I also heard from a few other healthcare systems. Also just have questions about the trust fund and its future. So,
Exactly.
yes, I would appreciate that too. Thank you.
Okay, so may I have a motion?
So I will make the motion to approve the consent calendar, adding item 9 to it, and deferring item 14 to the budget hearings.
Perfect, yes, and I'll second that. Anybody in the public would like to speak on these
We
items?
do have a request to speak on item 9 in the room, Allison Brunner.
Okay, 2
And then-
minutes.
And then we also have a couple of speakers online as well.
All right, let's do 2 minutes each.
Allison, please approach the podium. Is Allison here? Oh, okay.
Good morning.
Morning.
I'm Allison Brunner, CEO of the Law Foundation of Silicon Valley, and thank you for giving me my morning back. I thought I was going to be talking deeper in the agenda. So, good morning. I'm here to ask that you respectfully reconsider the proposed 34% funding cuts to the medical legal partnership between Santa Clara County Valley Healthcare and the Law Foundation. This program, which is known as the MLP program, has operated for over 15 years and is a proven, nationally recognized model that integrates legal support with the healthcare system to improve health outcomes for low-income people. Last year, our MLPs, which include a pediatric MLP, one with VHHP, and one with the Valley Specialty Clinics, served nearly 1,000 children and adult patients, helping with urgent legal issues like unsafe housing, benefit permits denials, immigration concerns, and educational access, challenges that directly affect health and well-being, the social determinants for health. Cutting this funding would mean that at least 331 patients would lose access to these critical services and inevitably lead to worsened health outcomes. We're already seeing increased demand. Our homeless health program caseloads have doubled in 4 years. It's also important to acknowledge the legacy of this program. It was the first MLP at a county hospital in the United States, and it continues to reflect the dedication of the county's exceptional doctors and medical staff, and also the innovative approach addressing the social drivers of health. I just want to say, and please know, that we recognize the tremendously challenging and uncertain times that we are now in. That said, I do appreciate your understanding that I have an obligation on behalf of all of our clients to make sure that the impact of any funding reduction is on record. So thank you for your time and consideration.
And we also have online speakers. Kenneth Horowitz, you'll have 2 minutes to speak. The timer will start when you begin speaking.
Good morning again. This is Dr. Ken Horowitz from your Health Advisory Commission. I did send in a public comment on item number 9 regarding Mr. Lorenz's proposed budget initiative for 25-26. And the term he used was proper right sizing. And I didn't feel that just eliminating 104 vacant positions and 9.3 coded FTEs and better aligned staffing with operational and business needs goes far enough. As I mentioned earlier, we need to do things differently. And we need to shift primary care focus from the traditional model that we've been using for years into a more of a functional integrative medicine. We don't have to do it in every clinic, but at least we can get it started with a pilot. I also attached a link to a video from Dr. Mark Hyman, which will explain a lot about what our commission is recommending. You don't have to watch all of the 2-hour video, just watch the first 30 minutes. It's very informative. And lastly, in that proposed budget, there was a cut of 50% to the dental care services for veterans. Our dental gets very shortchanged in terms of the funding. We don't need to cut another $180,000 out of this veterans program. So please look at this proposal from Mr. Lorenz regarding right sizing, what that actually means, and the dental funding, which is being cut 50%. Thank you for your time. Have a great meeting.
Next speaker is Michael Rogers. You'll have 2 minutes to speak. Timer will start when you begin speaking.
Good morning. Thanks for your time today. My time is short as well. I'm teaching this morning in between physics and chemistry classes. But I'm the vice chair of the Health Advisory Commission. I wanted to comment on item 9 and follow on Ken Horowitz's comments with respect to the Health Advisory Commission's thinking about the budget situation and about how we practice medicine in the county. Functional medicine and metabolic nutrition are breaking waves not only in medical care but also in metabolic psychiatry, which is a rapidly moving science. It doesn't have as many of the challenges that regular medicine and nutrition have because there's less entrenched interests. So it's actually moving very quickly. There's a group here called Bazooki Group in San Mateo County is funding a lot of research, and that's moving very rapidly with Chris Palmer as the industry leader from Harvard on that one. But secondly, we're at a strategic point in this semiconductor business that I spent my career 40 years in. It's very cyclical industry. When the cycles happen, you got to think differently, figure out how to do things differently. My boss at Intel, Andy Grove, wrote a whole book about strategic inflection points, you know, starting with when they switched from making DRAMs, where they're getting their butts kicked by the Japanese, to making microprocessors. Huge difference in the company's future. We're at that point in medicine. 90%, 80 to 90% of our costs are in chronic non-communicable diseases, right? And increasing. We can't sustain this by any means. We're stretched even with or without the budget crunch. Metabolic nutrition, functional medicine, integrative medicines are ways to do things differently at lower costs, providing better outcomes, make patients healthier, and reduce the overall cost of the system are binomial output variables of doing something differently in this case. So I appreciate the efforts, and I know the work going on. We're actually meeting with some of the people in the county health system later this week to get an update on that. So thanks for your time and attention. Have a great day.
And that concludes our request to speak.
Thank you. Let's go and take the vote.
Vice Chairperson Abakoga.
Aye.
Chairperson Lee.
Aye as well.
Motion
Thank you.
carries. Thank you.
Okay, moving item number 4, recommendations relating to medical staff and allied health professionals at Santa Clara Valley Medical Center, O'Connor Hospital, St. Louis, and also now Regional Medical Center. And here to present the item is Dr. Patricia Salmon, Enterprise Medical Staff President. Good morning.
Good morning. Thank you for having me. Yes, I'm here to present and kindly request your approval for our credentials report for our physicians and allied health staff for Santa Clara Valley Healthcare.
Okay, thank you. We've got the report, and do you have any questions, Vice Chair? No questions? Okay. Any public would like to speak on this item?
There are no requests to speak.
All right, I'll go and close the public comment, and let's go ahead and entertain a motion. Receive the report.
I would like to move the staff recommendation.
Okay, and I'll go and second it. Let's take a vote.
Vice Chairperson Abakoga.
Aye.
And Chairperson Lee.
Aye as well.
Motion carries.
Thank you. Report's been received. Thank you very much, Dr. Salmon.
Thank you.
That was fast. Okay, item number 5 is recommendation relating to the federal and state health policy and budget landscape. And this morning we have our consultant, Bert Margolin. Good morning.
Oh, now it's on. All right. Good morning, supervisors. The big issue I want to talk about this morning is the potential for an historic cut in the Medicaid program. It's the issue that we're all tracking, all following very closely. For months, we've been dealing with speculation about the form and size of the cut, but we're past that now. We're within a few days about to enter the beginning of the real debate over specific proposals to restructure and cut the Medicaid program. The House Energy and Commerce Committee has a markup scheduled for Wednesday, May 7, 1 week from today, and they're going to try on that date to unveil their Medicaid cut proposals, take votes, and actually move a package forward. As you will recall, the committee has a cut target of $880 billion. Chair Guthrie, Congressman Guthrie, who's the chair of the committee, recently said, though, that he will probably propose Medicaid cuts more in the range of $500 to $600 billion. It won't be the full 880, which, again, is small comfort because that's still a $500 billion, an enormous cut in the Medicaid program. The committee will not unveil its exact number until that committee meeting. In the meantime, we've had a massive national movement to oppose the Medicaid cuts. California, other states, pressuring members of Congress very aggressively. And it's had its success. There are a number of Republican senators who have expressed opposition to major Medicaid cuts. And potentially of even more significance is there are many House Republicans, the margin's so narrow in the House, who have publicly declared that they will resist Medicaid cuts.
That's great.
A Don't Cut Medicaid letter organized by Congressman Valadao 2 weeks ago, signed by 12 Republicans, was a
Finally.
prime example
Finally.
of that resistance building, which is all very helpful. Although, with Medicaid, the devil is always in the details. So it's important to note that in the language of the Valadao letter, there are areas of concern. For instance, the group of 12 did say that they would support targeted reforms that would reduce improper payments What exactly is an improper payment? There are House Republicans who for years now have taken a very expansive view of an improper payment, and to sort of connect it to Santa Clara County directly. As a public hospital system, we receive special directed payments through managed care as an incentive to improve quality in our system. Other public hospital systems receive these kinds of payments. They're paid to other kinds of hospitals as well. They, in the view of some House Republicans, have been considered an improper payment because, number one, they're not part of the traditional, original Medicaid program. There's something relatively new, and they also have been growing in size. That, of course, does not make them improper. They're quite central to the financial viability of many public hospital systems, including ours. But that gives you a sense of where the debate might go. Not cutting beneficiaries, going after quote-unquote improper payments that are anything but improper. The letter also declares that they will fight against efforts to divert resources away from, and they're very specific on this, children, seniors, pregnant women, and individuals with disabilities, sort of the core Medicaid population. But they don't include in that list the childless adults, the adults, low-income adults without children, who were a major part of the Affordable Care Act expansion. That's the group that Obamacare brought into Medicaid, and they quite pointedly don't reference that in the letter. This is an area of possible risk for us, this expansion population. The letter does state, though, that they don't want to see Medicaid cuts that threaten the viability of hospitals. And that's encouraging because, again, regardless of how you structure it, what you call it, many of these highly technical proposals will threaten the viability of hospitals. And that's going to be a major area of contention and pushback when we see their proposals, if in fact they move in the direction we think they might. Now, there are negotiations going on literally every day in Washington. There are groups meeting with the House Energy and Commerce Committee chair. There are subgroups meeting, negotiations happening, and interesting developments. I'll give you a couple of examples. Congressman Don Bacon of Nebraska was one of the 12 who signed the Don't Cut Medicaid letter. He declared yesterday that he's decided that his red line on not cutting Medicaid is not one penny more than $500 billion. Which is not exactly where we want a red line to be drawn. And to add further confusion to his position, he said he's okay with $500 billion just as long as it doesn't hurt beneficiaries and hospitals. And of course, that's a statement that can't ever be reconciled because if they do $500 billion, they're going to hurt beneficiaries and hospitals. And that's the argument we're going to have to make when these proposals come out and to clear the air. There was also a statement yesterday by Congressman Mike Lawler of New York, who did not sign the letter, but who's been against Medicaid cuts. And he made a series of very definitive statements that he's not going to decrease the federal match. He's not going to support a per capita cap, and that's his line in the sand, and that's more the kind of line in the sand we'd like to see. We know that these negotiations are going on and that there's a target of a week from today, May 7th, but it's entirely possible that it'll be rescheduled given how complex this is and how much resistance there is. I do want to briefly highlight, though, the proposals that Republican members of the Commerce Committee have been talking about publicly that seem to have some traction and are on the tables, just to highlight the issues we may have to deal with a week from now or 2 weeks from now. The issue that has the most traction appears to be work requirements, the idea that in order to be eligible for Medicaid, or in California, as we call it, Medi-Cal, you have to be working, seeking work, or in some set of narrow exemptions. Work requirements, when they've been tried in other states, result in a significant decrease in the Medicaid rolls because in the states that have attempted this, they've made complying with the work requirement so onerous and the paperwork so complex, people fall off the rolls. And in some states, in some cases, they simply make the exemptions too narrow. They don't allow for all the family circumstances that can interfere with work. This is close, however, to a consensus position among House and Senate Republicans. They're all for work requirements. They've talked about saving $100 billion over the course of this reconciliation time period. They need, again, a lot more than that, and they may decide, we've heard this report, to make the work requirements even more onerous than we've seen in the past to generate even more savings. And again, when I say savings, it's in quotation marks. That really means people who can't qualify for Medicaid, who should be on Medicaid, and who are pushed off because of the paperwork and the bureaucratic roadblocks that are being set up. Another area that we're dealing with is the federal match. We all know that Medicaid is a program with state dollars matching federal dollars. And for the expansion population that we talked about, the Affordable Care Act, Obamacare expansion, largely childless adults, but others included as well, to incentivize states to join in this expansion, the match is 90%. 90 cents on the dollar comes from the federal government. It's a very generous match. It's been very effective. There are 41 states and the District of Columbia that have expanded the program based upon this match. Again, the vulnerability in the Valadeo letter is that they don't specifically reference the population this match is designed to cover. So this 90% match is a tempting target for House Republicans, but there's a problem they have in dropping the match and also saying they're not taking away benefits from beneficiaries. Several Republican red states that expanded Medicaid under the Affordable Care Act and took advantage of the 90% match said in their law that if the match is lowered, the moment the federal government backs away from 90%, the expansion is dead in our state. It's dissolved. So it's going to be hard for them to vote to lower the match and not trigger several states taking millions of people off the Medicaid rolls. So they're trying to come up with, again, this is all very complicated. I'm just going to give you a couple of examples. They're trying to come up with an alternative that would still cut the program, but would not trigger this automatic explosion of the expansion. And that's a per capita cap on the Medicaid expansion population only. We've talked in the past about per capita cap as a way of taking Medicaid, which is an open-ended entitlement, and basically saying we, the federal government, are going to limit our exposure and cap our exposure. And there are many ways to cap. The per capita cap says we're going to pay you a fixed amount of money for every individual you enroll, and that's it. We're not going to pay more. So with the expansion population, they would still have the 90% match. Fine. And they would pay, but only until a statewide cap is reached for that population. And when the statewide cap is reached, they would say, that's it. Your federal dollars are capped, pay for it on your own. It still would result in people losing coverage, but it would be more indirect. And that's the kind of stuff we're going to see in the next 7 to 10 days. Proposals that will sound moderate or technical, but will have a draconian impact on people being eligible for the Medi-Cal or Medicaid program. There also are, speaking of technical, and I won't go into detail on any of this, a number of proposals that they may come out with that will sound very benign, involving the directed payments I talked about a minute ago, the special payments that we get to reward us for improving quality in our program, or that might deal with something called provider fees, which are ways in which hospitals help states put up the state match. It'll sound technical, it'll sound benign, but these more technical mechanisms may result potentially in massive cuts to the Medicaid program. So now, timeline. Speaker Johnson has talked for months about getting this done by Memorial Day. That's always been unrealistic. We've talked about this in the past. And now Speaker Johnson has acknowledged it can't be done. It's important to remember that this process just doesn't involve the House coming to agreement. They have to negotiate with the Senate. The Senate doesn't like any of this in terms of process. They wanted 2 reconciliation bills, one dealing with border control and defense to be passed quickly, and they knew negotiating these big cuts tied to the tax cuts would take a long time. But in the end, the president and the House prevailed on strategy. So they're trying to do one bill, one reconciliation bill. But once the House, let's say they pass it by Memorial Day, the Senate In order for this to become law by the new target date they've established, July 4th, the Senate would have to negotiate with the House and get everything done perfectly in the 30-day window. That is unlikely to happen. It could happen, but it's unlikely. They have a July 4th target date. That could slip to August, could slip to September. But there is one event that could provide a hard target that can't be slipped or evaded, and that is the debt ceiling limit. House and Senate Republicans have decided that they're going to deal with the debt ceiling, not in a standalone bill, which they could do, but they want it folded into reconciliation for a range of reasons. And they have differences on how to do it between the House and Senate, but they both want it done that way. Where the hard deadline occurs is right now we're past the debt ceiling limit, and the Treasury Department is using what they consider extraordinary means to patch together their ability to spend money and meet federal obligations. There is something called the X state, where the Treasury Department will declare where we've run out of extraordinary means. We're going to default. The federal government will default unless you give us debt limit relief. And the Treasury Department within the next week is supposed to announce the X date. So we may see all of this accelerate and all the schedules we've talked about changed based upon a Treasury Department X date declaration. And then to leave before I open it to your questions, before I go to that part of the agenda, I want to briefly mention on the state front, there is one issue we're tracking that would have a significant impact potentially on Santa Clara County and other public hospital systems. State's facing its own state budget crunch, and there have been reports in Sacramento for a while now that the governor's office has been looking at the possibility of rolling back the state-only Medicaid expansion that covers undocumented individuals. This is something that was done between Jerry Brown and Gavin Newsom over a decade in increments. First children were covered, then seniors were covered, and then young adults, and then middle-aged adults, so four increments over a decade. And because of the Medi-Cal deficit this year, there's at least been talk in the Capitol about the possibility of the governor trying to do something to solve the Medi-Cal deficit by rolling that expansion back. It may not happen. This is speculation, but I wanted to, since we're going to see the May revise within a short period of time, I just wanted to flag that is an area of concern in Sacramento. Happy to respond to questions. That completes my report.
Thank you, Ms. McGowan. This is very helpful. And I see a light from County Executive James Williams up. You probably want to talk about this Medi-Cal issue from the state, which I think we've been talking about this last week with this legislator, why those numbers are so high when people are just getting into the system, right? So go ahead.
Yeah, that's right. So first, just want to thank Bert. I think he's done a good job laying out just the magnitude of what we're facing. And at the federal level, just to speak first to that piece of things, we're going to see a lot of shenanigans of describing major and massive cuts to the federal Medicaid program as not affecting beneficiaries or not affecting or impacting hospitals. And the reality is, of course, that's where the money goes. And it's going to be a big lift. And I share Bert's perspective that the letters that have come forward from some of the Republicans who are trying to suggest that they are opposed to Medicaid cuts are actually not very helpful. And the space that they have left in those letters basically is a menu of a series of very devastating cuts to the program that could have a significant effect on our system and our finances. And when I mean significant effect, we're talking about major dollars. And also, and I think we have to keep this importantly centered, the really powerful impacts that this will have on the families of individuals who will lose coverage. There was a very powerful piece that I read recently about the impact of work rules in one of the states that imposed work rules that was describing a 40-some-year-old individual who actually was working but had inputted his hours in and then failed to realize that he needed to upload that every single month. Coverage got dropped. He showed up for his critical medication for his chronic condition. Ultimately, today, he's sadly passed away. But it tells the story of that impact that happened. It was an incredibly powerful piece in Politico. But these are real people who are dependent on health coverage to deal with their own health conditions and the impact that then has on their families. And we can't lose sight of that in the conversation, even as we will, of course, be also talking about what that translates to in terms of dollars and cents to our ability to operate this critical safety healthcare system. But what we're seeing at the federal level concerns me greatly. It seems pretty clear based on the express language from some of the senators who would be most pivotal to our efforts, such as Senator Collins, for instance, that we will almost certainly see work rules imposed. And that story I just shared was related to just a work rule change, not any other change in the program. And undoubtedly, thousands of individuals in our county alone, leave aside millions across the United States, would be very negatively affected, even if they meet eligibility criteria by the imposition of those rules. The concern at the state level, and President Lee is correct in describing what we heard when we were up in Sacramento last week. The signal was very strong. I wouldn't say it's a rumor. I would say we were basically told that the May revise is going to include very significant changes in eligibility or other rules to, quote, cost contain the state-only Medi-Cal program. And again, this is very concerning because of the impact on the individuals, but also because it's very short-sighted. It should surprise no one that when you finally give someone health insurance, when they haven't had coverage for years or decades, that they all of a sudden need lab work and they need other tests and you discover chronic conditions. And the whole point of getting them on health insurance is so that you can stabilize those conditions, realize long-term cost savings by avoiding having those individuals come into the emergency room for treatment of an emergent situation as opposed to actually controlling and treating the chronic condition. So I don't know what modeling they were using, but it is not surprising to us who actually deliver the health care to these individuals that in the first years of the program, there's significant increased utilization. And cutting that eligibility off, ironically, is going to be extraordinarily costly in the longer term because you're actually then not realizing the cost-effective benefits of actually having the program in place. The other thing that is very concerning about this is as we shared with our delegation, the state has an opportunity to either exacerbate or mitigate federal impacts. We know it can't backfill for everything the federal government's going to send our way, but there's choices the state can make that either make things worse or that can help moderate and modulate what's happening. Layering state-only Medi-Cal cuts on top of federal Medicaid cuts severely exacerbates the damage to these critical healthcare systems, not only our public system, LA, and other public hospital systems in the state, but even those private systems that have been struggling, especially in the more rural parts of the state. So I'm very concerned that the state is not taking a strategic approach, that we're going to need to vigorously advocate with the legislature to actually have a little bit of a more medium-term perspective and horizon on what's happening and to ensure that the state doesn't layer on very damaging cuts that could undercut the bedrock and foundation of these vital public institutions and other healthcare institutions in the state. So we're facing extremely challenging headwinds. We'll talk more about this, of course, at the budget workshops in a couple weeks. We do not have accounted for in the actual budget proposal cuts to the current federal Medicaid or the state Medi-Cal program, but anything that does come that way will be extremely damaging And like I said, we're talking about the health and well-being of individuals that thereby affects their entire family and our community writ large. So I'm extremely concerned about what's happening, and we will, of course, be as vigorous of advocates as we possibly can be, both in DC and in Sacramento. I strongly urge everyone in our community who cares about these issues to gear up now for what is going to be, I think, a very significant issue in Sacramento when the May revise drops in a couple weeks, because we just cannot have the state layer those on top of what's coming our way from the federal government.
Thank you, James. Let's see, anybody in the public would like to comment on this item?
There are no requests to speak.
Okay, I'll close the public comment period. Thank you, Mr. McGowan.
Thank you.
As always, very comprehensive report, and I know things in Washington, D.C. has moved very, very quickly. This is the 100th day after the inaugural, and it's amazing how much has occurred. I felt like a lifetime has gone by, at least a year, it feels like, not just 100 days or 3 months. And certainly, it's still not anywhere near over, as the president has already mentioned yesterday. This is just the start, this is just the beginning. So we have a lot more that we rely on you to keep us posted what's going on. Thank you, Mr. McGowan, for keeping track of all these really light speed type movement over there, creating a lot of, unfortunately, pain and chaos, and frankly, very cruel in some of the layoff and whatnot that we're seeing throughout the community. And I just want to say that what is 880 billion or 500 billion? Let's be serious. This is really cuts to people's basic health needs, not just this county, but around the nation. And I'm glad to hear that there are some Republican Congress members are realizing how painful this is to stop this train wreck moving forward. But I do really think that we need to keep up the pressure and keep everybody informed how important this is going to be, because even though we just acquired our regional medical center in April 1st, which we're very happy about, without the funding coming through, we won't be able to maintain it. Thank you. All right. Any further comments? Go ahead.
Thank you. And thank you. I do appreciate the extensive summary and keeping us updated on what's going on, and it's ever changing. So, and with a lot to follow. But I wanted to ask staff. I know that there's just still a lot of uncertainty, but I think we get asked in the field quite a bit, what's going on? What does this mean for the county? And I appreciate, I even just saw an email come through from our healthcare system. But how are we relaying this to the public? And then moving forward, do we have some sense? Now, I mean, there's definitely deadlines now, the debt ceiling, whatnot. But are we starting to, I'm assuming our budget, our finance department is doing this, but modeling out different scenarios, when will we start to see that? You know, how do we communicate what's happening? Like you said, the could be very dire. I've shared that with my district constituents, but like, what does this, really mean concretely, and how we are going to deal with it? Like, what is our timeline in trying to roll something out?
So there's a few aspects to that make things kind of a little complicated to model. So not only do we not know what specific types of changes would be forthcoming, which would affect different types of funding streams and programs, but because Medicaid is a joint federal-state program, the state is then going to turn around and have decisions to make. So take, for example, the expansion population. I think one of the likely federal cuts could very well be to change the 90-10 split federal-state share for the Medicaid expansion population. If that's lowered to 80% or 75% or lowered all the way down to the 50% current floor, California then has to decide, does it drop that coverage, or is it going to backfill that dollar amount? So then if reconciliation passes and does that cut, then Sacramento is going to have to make decisions about whether to make changes to who's then covered by the program and to either drop that or not. So then there'll be that interaction, right, that we will have lobbying at the state level. After the state makes a decision, if the state then decides to turn around and drop that population, then we would, of course, have, you know, thousands of people losing coverage here, and we'd go back to a situation where we would then have a discussion with the state around some changes that were made in the county-state fiscal relationship that came out of the Affordable Care Act, including the expansion population, where the counties and the state fiscal relationship around healthcare funding was modified in part because counties were then expected to benefit from the expanded population. So, for example, would the state, as part of that, unwind that and go back to a situation where there was more direct funding being provided to public systems, for instance? I give that as that's just one possible change. And so I give that as an example because there's not just one action, but in that instance, at least 3 separate, very significant actions, 2 of which are at the state level where, candidly, we have more ability to influence the conversation, certainly, than DC, where we could, again, the state could exacerbate or mitigate the damage, especially to public systems. And so there'll be discussion then about what that means for California's remaining significant public healthcare delivery systems. What I can say is, you know, we receive around $750 million in these supplemental federal Medicaid payments. And that the Medicaid funding that we receive in total on the current year's budget is $1.9 billion. So, you know, if those directed payments and supplemental programs and waivers all terminate, it's a strict kind of that's a kind of more straightforward analysis, which is, you know, we'd be looking at a $1 billion hole in our budget. I think it doesn't require sophisticated modeling to recognize that a $1 billion hole in the health system's budget would result in catastrophic cuts, widespread need to shutter service lines, and massive layoffs in the system. That's just, I think, pretty self-evident.
Thank you very much. Okay, all right, let's go ahead and take the vote on this item.
We have a motion.
Motion approved.
Motion to
Receive the report.
receive the report, and I'm sorry, I just completely lost my, it says consider recommendations relating to the federal and state.
Right, and yeah, those are, but it's just to really, just to receive the report.
Okay,
Yeah.
I will make a motion to receive the report.
I'll go ahead and second that.
Vice Chairperson Abakoga
Aye.
and Chairperson Lee.
Aye as well.
Motion carries.
Thank you very much. Item 6 is regarding a report from the Behavioral Health Services Department relating to ALCOVE, Palo Alto.
Good morning, Chair Lee and Supervisor Abe Koga, Sherry Terrell, Director with our Behavioral Health Services Department. Our staff are getting set up here, and then we'll go ahead and have them introduce themselves, and we have a brief presentation and update on ALCOVE.
Great, thank you very much, Sherry.
Good morning, Supervisors. My name is Zelia Faria-Costa. I'm the Children and Youth System of Care Director for Behavioral Health Services, and with me today I have Jennifer Pham, who is one of our division directors. She's going to be doing a short presentation, and then we can answer any questions that you may have.
Great, thank you.
Good morning, Supervisors.
Morning.
So today we will be presenting on some updates in regards to our ALCOVE Palo Alto Center. Next slide, please. We'll be going over program overview. We'll provide some program highlights in terms of the data for the past calendar year. We'll share some outreach and engagement community supports that we've been providing, and then ongoing efforts that we are looking forward to with Palo Alto as well as other grantees for the ALCOVE model. Next slide, please. So quick overview of the program. ALCOVE was established in 2021 as a community site to serve youth and young adults ages 12 to 25 with mild to moderate needs. Our focus has always been on youth voice. The center was built around for the youth, by the youth. So we have the essential component of our youth advisory group, which consists of about 12 to 15 young people ages 16 to 25, representing diverse backgrounds from the community. And they provide supports around policies, around structure, and services that are provided at the center. Our core services include our mental health services, substance use prevention services, which is encompassing our behavioral health supports. We have physical health services, supported education and employment services, peer services, as well as educational workshops and social events. And the model has always been, and the purpose, the goals of it is to support and combat stigma, provide mental health well-being, foster community ties, and provide culturally sensitive services. ALCOVE provides workshops to the youth and caregivers in the community. Excuse me. They're youth-oriented workshops that are developed by the collaborations that we have in the community. We have our youth advisory group and our community consortiums that lends a lot of feedback to what we provide to the center and services that we put in place. We have shifted our workshops over the various years to really accommodate the needs that have been provided to us, or the feedback that has been provided to us for the services that should be delivered at our ALCOVE site. Next slide. So here's some highlights in terms of the data for our calendar year 2024. Just to highlight, we have seen for the calendar year, 362 youth have visited the center, with 222 completing an intake packet which would provide them supports in the various core services that you see up there, and then 376 youth participating in workshops that have been delivered throughout the year. One of the key takeaways we wanted to highlight here is that our services have been similar throughout the years that we've been open. Our highest rate of services has been for our behavioral health services. We see also the similarities for our C and our peer services as well. We have increased workshops, again, because of the voice of the community. We've really catered the workshops to what the needs are in the community, so we've seen more youth coming in to attend. We've also offered more opportunities for it, so we provide services or workshops on an average of 4 days out of the week, and that way we're able to catch youth before or after other services that they may be participating in. Next slide, please. A little information in terms of our satisfaction surveys that are provided at the end of each service delivery stream that we provide to the community. It's similar to what we see in past years. We have, for this past current calendar year, we saw 77 youth completing a survey. Of that, 93% of them would recommend ALCOVE to a family or friend. 95% have felt that they are heard, understood, and respected by the ALCOVE staff, and 95% saying they're satisfied in the services that they provided. As I mentioned, this is consistently what we were seeing for the past calendar years as well. Some highlights in terms of what we have been doing in terms of our outreach and engagement to the community. The community networks that we've built up in these past few years, you can see that whole host of providers, community-based organizations that we participate with, and this is just a snapshot of what we do. Collaborations with other entities within the community. Our community voice, our YAG, is a huge component of our service delivery, our community consortium as well. And this past year, we've worked with Homestead's High School's Future Business Leaders of America to develop some of that outreach materials as well. We provided educational workshops with our community schools, like Palo Alto High School, there's a typo right there, Gunn High School, Green Middle School, Mitchell Park Library, Alta Housing, and Little Blue House to provide some of those activities that you see there in terms of therapeutic supports or slime making, aromatherapy, some fun activities as well, like Mario Kart Prime. We've also done presentations and informal sessions in the community at some of the high schools and schools around the community, as well as at summits, the annual children's summits, Palo Alto Community Health Fair, and then we held an ALCOVE Palo Alto annual open house where we did presentations, we did workshops, and just invited the community into the center. We participated in tabling events as well, just again, get the word out of ALCOVE, provide the services that are available there, and just educate the community as well in terms of what is mental health and reducing that stigma. So our ongoing efforts, we are continuing to engage diverse communities. We've partnered with some, community services to really build up and support outreach to our Asian American Pacific Islander community, our Black African American community, and neurodiverse populations as well. Again, putting out workshops to support that, and just partnering with some of our community providers through such as the Palo Alto Unified School District, Black Student Union, Micom Community Center, FLY, Little Blue House, all those things to really outreach and market the services that we provide and that is culturally appropriate. Sustainability and funding outlooks. Since ALCOVE's implementation, we've been working really closely with the OAC, as well as with the Stanford Psychiatry Center for Youth Mental Health and Wellbeing, and other ALCOVE grantees as well, to think about and explore those strategies to really sustain our ALCOVE model and services in the community. I believe that's the end of it. That's the end of our presentation. Any questions?
Great, thank you very much. And let's see, is any in the public would like to speak on this item?
We do have a request to speak online.
Okay, 2 minutes.
Paul Soto, you'll have 2 minutes to speak. The timer will start when you begin speaking.
Yes, Paul Soto from the Horseshoe. Thank you for the report. Number one, you're not defining what behavioral health is. There's no definition for it. So as a member of the public, how do I know what that is? I don't know what the standards are in terms of efficacy and targeting the issues that you're addressing. Secondly, you also don't have the eligible amount of people within the age groups that you named. Like, how many people are in Palo Alto in that age group? And then you give me these numbers. So these numbers don't say anything, and it frustrates me that you guys come in here and you try to pass this information off. Well, this is how many people did this service, this is how many people did this service, but we don't know the entire scope of what it is that you're doing unless you provide us the demographic information that's necessary to determine whether or not those numbers are effective or whether or not you need some more work. You see, and it's done like that intentionally, and I don't appreciate that. Okay, I go to these meetings, and I've been going to these meetings for 6 years. I do my own research, so I'm not coming at you with an uninformed position. I know what I'm talking about because I know how to analyze data, and this data is incomplete. If you do not have the amount of people that are actually eligible for this service, and then comparing it to the people that are accessing the service, because I'm pretty confident that if you got those numbers, you would see that these numbers are very, very low, and that they need to be brought up because of the amount of people that are actually eligible to receive this, but they're not. And so those are the two, and the difference.
And that concludes our request to speak.
Thank you very much. Vice Chair, you have any questions, comments on this item?
Yes, thank you, Chair, and thank you for the presentation. This is of high interest for me since it's in my district. I very much appreciate the facilities and the services provided. I had an opportunity to tour the facilities, and I appreciate Mr. Steve Eckert being in the audience, but he gave me a great tour. Obviously, the services are important, and I appreciate that we have this in District 5, but actually Mr. Soto brought up some good questions, and of course I'm still new, so I'm getting up to speed on this. I remember conversations about the establishment of ALCOVE as a city council member, and when they were when I guess the county was discussing this, and I think there's also some state funding that was involved. I remember Senator, I think it was Senator Bell at that time, talking about some state funding availability. But to be frank, my real question is, or just the concern is the cost. The cost per participant is extremely high, and in light of our financial situation, I'm having trouble being able to justify the cost. I also, I guess I do have questions about what our role or purpose or goal is here. Some of the services, and they're wonderful, but I know now that they have a teen center in Palo Alto, just about, maybe not even a mile away. Each of our cities, Mountain View has one too, I believe Los Altos does, and I know this seemed very, like from reading the history, it's very specific to Palo Alto, but again, going back to my remembering the conversations of the establishment, it was really meant to serve District 5. And I think that's not, it's challenging when you have it in one location. That tends to be like the furthest out, frankly. And then transportation becomes a challenge for this population as well. And frankly, I think, as I've learning more about the issues and around behavioral and mental health, thinking that is the model still the most effective way? I've now, especially during COVID, there's therapy sessions that were having been done in Zoom. Like, is it? And frankly, during that time when we were, dealing with even the city operations, we had to realize that we couldn't expect people to come to us. We had to pivot and go to the community. So thinking about all of these questions, I guess my question to you is, how are we looking at trends? How are we looking at finding a more cost-effective way, frankly, to provide these services? I have ideas, like I mentioned, there are teen centers. Like the one in Mountain View is quite large. I haven't talked to them yet, but I've often wondered if we could be offering, therapy sessions there, because the cooking, baking, and all of that, that's all happening in these other facilities. So I'm just not sure that we need to have the duplicative services, and if really we focus in on what our purpose is, and if that is to provide mental and behavioral health programs, could we do this in a more cost-effective, efficient way?
James, go ahead.
Yeah, and I'll let staff speak to kind of the service delivery model, but Supervisor, I really appreciate you asking some of these questions, because I'll just speak to kind of the higher level fiscal situation. We're facing kind of the triple threat on our behavioral health services funding, which is not only is a quarter of that department's budget overall from Medicaid, which we just talked about, a few minutes ago, but the other two main funding sources, in addition to, of course, County General Fund, it's actually a quadruple threat. The other main funding sources are the 2011 realignment, the County General Fund, and MHSA, and all of those funding sources are having challenges and structural deficits. This program has been funded with MHSA funding, and there's been shifts in that, and as the state transitions MHSA to the Behavioral Health Services Act, the specific category of funding within MHSA that's been utilized to support this program is going to come under increased pressure. So when it was originally launched, it was through the innovation component of that funding. That ended December of 2023. And then the funding has shifted to a different bucket within the MHSA funding, but that bucket is now coming under pressure because not only are counties receiving less MHSA funding, period, but there's now mandates from the state that that the funding that counties do receive be shifted towards housing and other intensive services and away from these prevention and early intervention and other categories of services where we've really done a remarkable job across the community, across the system with our investments. So this is one of many programs that will have to have a hard look because that funding stream isn't sustainable for a range of programs, this being one of them, and we're going to feel significant pressures there. And I'll turn it over to the department to talk more about some of the other questions you raised about the different models. But I think you're asking exactly the right questions, which is we will have to look at what are the most cost-effective approaches, what are the right partnerships,
Yes.
what are the right partnerships so that we can co-locate, pool, and otherwise combine complementary programs and services, because the cold hard reality is we won't be able to just maintain what's currently funded just moving forward with the existing MHSA funding because of that state reallocation.
Yeah, and then part of that too is, I was going to ask this later, but I've noticed as I drive around, frankly, we have a number of clinics and facilities really within a 1.5 mile radius. And I would like to actually have give me an option to report on what's in all of those facilities. But we just opened the health clinic literally down the street from ALCOVE. And so I'm just thinking about the facilities that we have. And then going back to what are we trying to achieve with this? Obviously, I don't want to lose the services, but yes, again, is there a different model of delivery that can be more effective? Is what I really want to get at.
Yeah, no, I think these are exactly the questions that we will need to collectively grapple with in the coming year. But I don't know if staff want to add on to any of the specifics related to ALCOVE and some of the questions around the service model.
Yes, I can add up to that. So ALCOVE is a model that we are needing to hold fidelity to that model, which is the core components in there in a standalone center to provide services to the youth in the community ages 12 to 25. So we are holding to that fidelity model where we're pushing in the services into the center. I hear what you're saying, the supervisor. There are workshops that are available on the community, similarities. We do partner with the teen center and provide services, in both places. They come to us, we come to them. So we're building those partnerships to be able to provide and outreach more into the community. But we are holding true to the model, the fidelity model of ALCOVE as well.
Do we have to, but then given that funding seems to be running out, do we have to continue it this way?
In order for it to be an ALCOVE center, we do have to hold the fidelity to the model. The OAC holds the trademark for ALCOVE. And so there's a central ALCOVE. James, did you want to?
No, I was going to say, I think the point, the broader point is we will have to have the difficult conversation around the sustainability of all of these programs and re-envisioning them. I think what you're hearing back is, in order to be designated, quote, an ALCOVE program, it has to be in this particular format with this particular model. But the broader question is, how will we have to allocate limited resources for the broader bucket of that service delivery? And we're going to have to grapple with that, and that will mean the difficult conversations around revisiting the existing programs that we have, and whether, in this instance, whether, and no decisions have obviously been made, right? And there was ultimately that's a decision for the board. But one of the considerations will have to be programs like ALCOVE, as well as many others in the behavioral health space. Are we able to continue fidelity to those programs, or do we have to modify what we're doing, given the fiscal constraints?
Yes. So, if we need to keep it intact, the other alternate or option is to look for partnerships. And again, I haven't talked to the city of Palo Alto, but maybe there are opportunities, because the range here is 12 to 25, which is a very wide range, and I think the teen center is targeted towards middle school students, right? So through the high school students and the older youth need a place. I went to visit the hub, which is wonderful too. I don't know enough about this, but can some of those services be brought in so that we don't have just one in San Jose, but a North County hub? So just thinking about what else can we do? I mean, I don't know if that would break the ALCOVE model, the branding, but I just, think that we, again, what I keep saying this, but, I very much admire what we've done. It's just, again, we're in tight times, so we're just going to have to start thinking about things differently. The other item or question, and I know there was mention about multicultural services, and I just want to emphasize that. I'll be meeting with the suicide prevention folks later this afternoon, and just reading about that. And I've seen it too in our communities in North County, the rise of suicide tragedies in especially among Asian American youth that I see, and I know the Latinx community is experiencing the same. And in light of actually where the location is, I think there is definitely a lot more work we could do in that area. So, Chair, yes, thank you.
Sure. Let me try this. So first of all, I just want to thank staff for a very thorough report. This is very informative, and also to see that this program, many times we come up with great ideas, come up with a program, and sometimes it's not very successful. This is the one of those that we say, wow, this is doing really great. I know we have some challenges in the San Jose ALCOVE site, but as far as the Palo Alto site is concerned, this is definitely one of the success stories. I want to give you a lot of commendable accolade to the staff for all the hard work to put this all together. Funding, of course, is a big issue. As you heard earlier today, we're getting a lot of cuts from Medicaid and whatnot from the federal side. But locally here, how can we make sure that this continues? I think is very important. Another issue that I am concerned about is also regarding the number of partnerships, because, for example, I believe we currently have a couple of MOUs being signed with VHC and Stanford, and that's great. But I think if we are able to get more partners, MOU signed that like some of the other ALCOVE centers across the state, we might be able to get more outreach and community engagement that potentially could lead more youth to be participating in the services that's offered. As we've seen, those who comes in have a huge 93, 95%. These are off the chart numbers of people really excited about how well ALCOVE is doing. So it's matters really bringing people in. I think is so important. So I would like to try this as a motion and see if there's something that's doable. I'd like to ask the BHSD to come back at the September HXC meeting with these three following things. One, a complete sustainability plan to reduce the reliance on MHSA PEI funding with recommendation from state ALCOVE financial consultants and continue ongoing operations, whether it's expanding the Medi-Cal billing, leveraging the CYBHI multi-payer fee schedule initiative, Proposition 1 funding, or BHSA prevention funding, or community benefits fund from a local hospital, Valley Health Foundation, or funding from any other sources to improve our sustainability plan moving forward, number one. Second thing is to create a plan to increase the number of MOUs with community agencies for additional support and marketing ALCOVE services to hopefully get the word out better. And three is to look into the possibility of creating a plan to increase the adolescent physical health services and psychiatry services, because currently the 4 hours of adolescent physical health on Tuesday afternoons and psychiatry on Wednesday afternoons are frankly insufficient. And if these two services being reimbursable, how we may be able to get funding for it by increasing the number of hours. And I'm going to throw this out as a question for staff. If these three proposals is something that is potentially doable in the future?
Yes, we can certainly work on that. I just wanted to make one comment about the number of hours for the physical health.
Yes.
We actually had done a study, and we had more hours available, and it was based on utilization that we recently actually reduced the number of hours. But we can definitely look into it.
Okay, good, because I know those are billable, i.e. reimbursable. That's a word I've learned now, sitting in the HXC all these years is, oh, wow, this is something you get paid for. If that's the case, why not offer it? But of course, we want to make sure people are truly using it. People not using it because there's such a low need in community, which I don't believe so. I think it's a matter of outreach of people not knowing these services being offered, or the hours are a little bit too hard to get to. So I'm just trying to see if we can offer maybe more different dates, for example, or whatnot, in order to make sure that more folks could be using the services. So if we could look into that in the future, I really appreciate it. Thank you. Yes, I see the lights on, Vice Chair. Is this something you would be able to second, and we can discuss?
Yes, thank you for summarizing it. I'm happy to second it. I actually just wanted to see if I could ask to add some financial modeling on this. So I'd like to just see, and I know it's all estimates, but how we can get down the per individual cost
Per
down.
person, yes, it's
Because right
very
now,
high,
I'm
correct,
looking
yes.
at it's like about $100,000 an individual that's being served, using the $4.25 million budget with the 300 and somewhat folks. So, yeah, I'd like to see how we can bring that down by the various strategies that you
Yes.
suggested, Chair.
I think it's like our VTA system, right? It's like
Yes,
the
like
train has a
per
run,
passenger.
the bus has a run, right? So
Yes.
those are kind of fixed costs. You couldn't really lower the cost. The key to reduce is really having more participants using
Well,
it, right?
frankly, though, there's, issues like rent, and I don't mean to micromanage this, but I mean, these are the things that I do look at. And, I guess right now, rent is cheap for commercial property, but, is this the best value we can get? Is there some other location near the area that might be, lower cost? The physical health piece, I guess that was my question with the new North County, the clinic down the street. Is there a way of consolidating there? Like, maybe folks, if they see it's a health clinic, they're more likely to go there. I don't know enough about the services and whether that can happen, coexist. So those are the types of things that I would like more information on. And if you could bring all of that back to us, that I would appreciate it. So
Thank you, Vice Chair.
thank you. And so I'll second that motion
Okay, all
with
right.
those
Sherry,
inclusions.
go ahead, please.
Yes, I was going to say, that'll be doable for September, and, hopefully by that time, too, we may have a better understanding of the larger fiscal picture just overall, and we'll be able to bring that information into our decisions around ALCOVE.
Thank you very
Thank
much,
you.
Dr. Thoreau.
Thank you.
Thank you. All right, no further comments. Let's please vote.
Vice Chairperson Abacoga.
Aye.
And Chairperson Lee.
Aye as well.
Motion carries.
Thank you. All right, item number 7 is a report from Santa Clara Valley Healthcare relating to the acquisition and integration of the Regional Medical Center, RMC. And I believe Paul Lorenz.
Thank you, President Lee and Supervisor Abacoga. First of all, I have to say that the integration of RMC into the county health system has gone very well. It has only been 30 days, and by all measures, we are frankly ahead of schedule. And what I mean by that is that we did not anticipate the census to be what it is today. The average daily census at regional is around 140. On some days, it's over 160. That represents a 55 to 60% increase over when we had acquired regional on day one, which is quite remarkable. But also what's happening is that the ED visits remain high, with an average daily census in the ED of 220. And on some days, once again, it could reach up to 240, 250. To date, we've had 110 trauma activations, 81 stroke, 39 STEMI activations. The surgical volumes continue to grow, and that has only been limited in terms of our capacity to open up more OR block times for elective cases, and we are moving forward on that. In fact, we will be opening up another OR in June so that we can, again, bring back elective cases and we can allow the physicians to have more time to do their cases at Regional Medical Center. So that obviously results in additional pull-through business relative to diagnostic imaging, laboratory, and other services. So from a financial perspective, we are seeing our average daily gross revenue continue to grow and move to be on par with the rest of the system. And I'm hopeful, given the types of services that we're offering at Regional, it will be much better than we had anticipated. I do have to, again, take the time to acknowledge the staff. We would not be in this situation if it weren't for their hard work and their dedication. And the reality is that I think as we're going forward and dealing with these additional challenges around the budget, this will allow us to leverage the system from your point, Supervisor Abekoga, about how do we utilize our facilities to their maximum potential and find those opportunities to leverage in terms of economies of scale, et cetera. With that being said, I also included in the report an update on the labor and delivery services, which both of you have inquired about. And clearly, we set a target by the end of the fiscal year, next fiscal year, to have that service line back in place. All indications are we can actually make that happen sooner than later, but we will return to your board with a recommended timeline and date. So we will come back with more specificity as we get more information. With that being said, I'm happy to answer any questions. There's a lot of information in the written report,
Yes.
but again, here to answer any questions.
Sure. Clerk, any public would like to speak on this item?
There's one request to speak online.
Okay, 2 minutes. Let's close it.
Paul Soto, you will have 2 minutes to speak. The timer will start when you begin speaking.
Yes, Paul Soto from the Horseshoe. Thank you, Mr. Lorenz, for the progress that you've made since the acquisition. There hasn't been any news. There hasn't been any complaints about lapsing in services. There hasn't been from the report that you just gave, things have been favorably making the acquisition and the transition has been moving along favorably. So I'm pleased to hear that. One of the things that had stood out to me most was when you gave the statistic that within a 5-mile radius of that hospital, 40% of the population is eligible for Medi-Cal. And they would necessarily be the population that would be accessing that service. And so, so with that said, it's really important that this acquisition and sustainability be maintained for this population. One of the things that I would like to talk about is that there was deficits though in that, like doctors, like some people went with the transition and others didn't, and there was numbers there, and so I was just concerned if those numbers have changed, and had they gone up, had they gone down, what areas maybe there needs to be some messaging or some hiring, because like I said at previous meetings, that was one of the issues that some doctors and some of the medical staff weren't necessarily making the transition. So once again, congratulations and thank you for your success.
That concludes our request to speak.
Thank you very much. Yes, I see the lights on. James, you want to add something?
I just had to take this opportunity to commend Paul, his team, the staff across the county organization that have continued to work diligently, as we've shared with the board previously. Not only was there work leading up to obviously the April 1st date, but that the integration work associated with regional would continue for many months thereafter. And we still have a ways to go to get to kind of what we would feel is the new kind of baseline for regional. The progress this month has been extraordinary. And Paul, I want you to repeat a couple of those numbers, right? Nearly 60% increase in the average daily census, the ED visits, the trauma activations. What that represents is individuals and families who are receiving care that were not didn't otherwise have access to that level of care at regional just a month ago. or otherwise had to travel to a hospital much further away with potentially worse outcomes. I mean, this is really making an extraordinary difference in that part of our community. It's also helping decompress VMC, which helps improve staffing outcomes, morale, et cetera, there as well. So I just have to commend the entire team that's worked on that. And as Paul said, how quickly we knew people would come with our ownership, but just how quickly that has happened has been remarkable. It does put some pressure on the staff at regional and the need to make adjustments there, but I think everyone is pleased to see just how quickly it has come back in such a enriching way in delivering this critical life-saving service.
Yes, Vice Chair, go ahead.
Oh, thank you, Chair. Yes, thank you. I just want to also relay my thanks and kudos to the staff for incredible. It really is an incredible effort to make this happen in such a smooth way. And I think about like what would have happened in the community if we weren't able, if this transition didn't happen. It's great to see the utilization. I noticed that even in some areas like STEMI, the numbers are the highest of all of our hospitals. Do you I'm assuming the census will continue to rise, but is there a goal? Is there, what are we looking to achieve?
So just to give you some perspective on when I say we're ahead of schedule, by year end, we were expected, in terms of our budget, to reach a census of around 175. We're at 160. We're only 1 month into it.
Wow.
So, there's some estimates that we may very well exceed 200 by year end. And there's a number of reasons for that, one of which is when we open up our ORs and start doing elective cases, we'll have more admissions from that alone, both in terms of our critical care units, but also our step-down units. So we fully expect that we could very well exceed 200.
Wow.
And what that means, two things, to James' point, is that we're providing more service to the community. Mm-hmm. And I would tell you the stories behind each and every one of those patients is quite remarkable. And the staff can tell you stories about how, obviously, the families and the individual patients have really embraced Regional Medical Center again. Mm-hmm. The other part of it is around the financials. Mm-hmm. And as you well know, operating in a hospital, the fixed cost is very high. Yes. So you have to have a reasonable amount of volume in order to sustain such a hospital in service to that community. So once again, we are looking to bring our expected financials in a much better position by year end because of the utilization of Regional Medical Center to the extent that it is today.
Great.
So.
Thank you. Thanks.
Thank you.
And I'm happy to make a motion to receive the report.
Yes, I will go and second that. Yes, cannot be happier to repeat those accolades. One of the questions I do have regarding the census, now that we are having these numbers going up on trauma, STEMI, and also strokes, are we seeing some type of a decrease at VMC, for example, due to the fact that RMC is online now to take those patients?
So, Supervisor, in general, what I can tell you is that it is too early to say, but I can share with you that the ED volumes at all three hospitals, and then plus St. Louis Regional, yes. 4 hospitals remain very high. Mm-hmm. The census remains, from my perspective, stable in comparative to prior year census numbers, but it is still too early to say. Mm-hmm. Because part of it is seasonality. This is the time of year that we start to see the census drop in our facilities, but we're not seeing that occur. Mm-hmm. I would also share with you that we've always had a backlog of patients.
Yes.
So I think that will allow for us to bring down wait times.
Exactly.
Or including not only in terms of our outpatient services, but hospital-related services such as diagnostic imaging, laboratory services, and other tests. The ED wait time and volumes at Valley have come down to a more manageable level. And I think all of us understand that they were under a very high level of stress given the volumes in terms of trauma activations. But I think that's come down to a level that's much more manageable. And I've heard from staff that they're feeling much better about the situation.
Good. And as we have also learned that a lot of folks go to ED because they didn't understand or know that urgent care was open at the time, have we been able to direct more folks about those issues when it comes to ED?
Yes, we have a number of different strategies that we are undertaking in terms of same-day appointments and urgent care access. And that is something that we will be sharing with this committee in future reports.
Good. Thank you.
In our operations report.
Yep, thank you very much. Yeah, I think those are all important strategies to make sure that we are able to reduce the wait time for folks, and many of them are directed to the right treatment in this case. So thank you very much. So really great news. It's only 30 days in, and so keep up the good work, so I could say. Thank you very much. Without further ado, we have a motion and a second. Let's take a vote.
Vice Chairperson Abakoga.
Aye.
And Chairperson Lee.
Aye as well.
Motion carries.
All right, moving to item number 8, a report from Santa Clara Valley Healthcare and Facilities and Fleet Department updates on the new De Anza West Valley Clinic. And I believe we have FAF Director Jeff Draper. Good morning.
Good morning, Supervisors. You have the report. As it indicates, we're still in the process of finalizing a lease agreement for the development of the Valley Health Center, West Valley. And I understand that the Foothill De Anza College will be taking this to their board for consideration in the next month or two. I'm not sure exactly the timing. And that's all I have for the report.
Okay, thank you. Let's see. Do we have any public who'd like to speak on this item?
There is one request to speak online.
Yeah, 2 minutes, please. Go ahead.
Paul Soto, you'll have 2 minutes to speak. The timer will start when you begin speaking.
Yes, Paul Soto from the Horseshoe. Racial equity within the context of health and healthcare accessibility is kind of like the premise of my comments, is that nobody in here, like, all Smitty did was come in here and say, we're going to get a clinic. And everybody just like went along with it. Now, if the Mexicans and the Chicanos on the east side said that we want a clinic, we have to protest, we have to fight, we have to threaten, we have to yell, we have to make a lot of noise, and we have to expel a lot of energy. In all of these meetings, I have not seen one college student, one person from that community that is going to receive this particular service come in here and request it. Say thank you. Say we really appreciate it. Nothing at all. But yet my community, we have to constantly beg, threaten, push, get aggressive. And that puts us in a very precarious position, because then it is perceived like we are being aggressive. No, we're not. We're experiencing an existential crisis. Do you know what an existential crisis means? It means that the mechanisms that are necessarily in place that would ensure our survival, that those rungs are slowly disappearing because the resources are being allocated in one of the richest parts of the entire state. Not only that, you have not only are you going to build it, but you're going to staff it as well. So that's going to take a significant amount of the budget in order to hire all the doctors and everybody that's going to be associated with it in terms of staffing. I mean, we really...
That concludes our request to speak.
Thank you. Go ahead and close the public comments section. Yes, Vice Chair, go ahead.
Thank you, Chair, and thank you for the presentation. This is another important project for our District 5, and very much support the concept of a De Anza College clinic. I know it's been, I guess, 4 years since it was approved. Frankly speaking, I think things I was a bit surprised, to be frank, and I need to, I guess, learn more when we do the budgeting about approving projects versus allocating funding for them. I see that that's the challenge that we have. I appreciate that there seems to be mutual agreement with the college district and us in terms of the terms of the lease and whatnot, but we now need to start to design and move forward with the actual build project, and we need to find some funding to do so. So I did want to say that this is an important clinic, and there is quite a bit of need in this area. The beauty of De Anza College is that it actually attracts students from all over the county, and there is, I've been told many times that quite a few come even from East Side San Jose. So it's a very far-reaching college and a population that is quite diverse and from all over the county. So I think that is a plus, a benefit to having the clinic located here. I'll also say that ever since it was approved, I've had many people come to me very excited to see that, it come to fruition and waiting in anticipation. So I just think that we really need to make good on our commitment and start figuring out how we're going to fund the actual project. So that would be one request I would have, is that assuming that we have a more favorable budget, perhaps next year, I'd like to see us be in a position to fund a design study for the clinic. And then the other thought I had was, since it's been 4 years and we'll probably have to wait a little longer because of the budget situation, been thinking about what we could do temporarily, some temporary solutions. And I've had some conversations with folks at De Anza or affiliated with the college. Online classes are more popular these days because of COVID. I'm wondering if we could talk with the college district to see if there's available space within the current campus. I know they have a clinic. Could we staff it with one of our clinicians? Or could we bring in portable trailers and park them on the parking lot and run a mobile clinic? So these are some thoughts I've had on what we could do temporarily until we get the longer term project up and running. So I'd like to request, and it's fine as an off agenda memo on strategies on how we could provide some temporary service as we look also at the long-term project schedule and funding opportunities. And then with that too, again, this being in my district and tied to the previous item we talked about, I'd like to get an off-agenda memo on the various facilities we have in North County, West Valley, to understand what's where. And I'd personally like to just see if there are other opportunities to maximize what we have already. Thank you.
So there's a motion?
Yes.
Okay, and I can second it and ask to see if we could also, on the off-agenda report, to talk a little bit about the financing of how we come up with funding for the VHCDNs. I think that'd be great. James, go ahead.
Yeah, we'd be happy to provide information. I think, we had this conversation in this committee about a year ago about funding associated with this project. And at that time, as I shared with the committee, we were not in a position fiscally to be launching new projects in the CIP plan, and there was no funding for new initiatives in the CIP plan for the budget that we're in this year. And that's similarly the case for the upcoming year budget as well. I think we can provide additional information, but we do need, this is one of the challenges with this project is not only the capital funding, but also the ongoing operating costs. I think it would be helpful in the off agenda for Paul and the team to explain the funding model for our primary care clinics, which is very heavily dependent on FQHC status in order to make the reimbursement model work effectively. And so we'd be happy to provide that information and continue to have this project move forward, but the funding hasn't been set aside, and I think that's been something that we have shared on several occasions previously, but hasn't been, I think, maybe as well understood by some of the folks in the community associated with this, and is something that would need to be addressed, of course, in the context of the overall budget. But we would definitely can return with that information, but I think both components are really important, which is the capital component, but also the operating component.
Yes. Vice Chair?
Thank you, Chair. Yes, so this is a case in point of what our conversation on referrals was last week, and part of my proposal was that moving forward, we do identify at least even preliminary funding sources. It's fine to approve things, but then I find that if there's no allocation of funds, they just sit on our list. And I really want to, I don't want those types of misconceptions in the community, to raise expectations and then say a few years later, oh, sorry, we didn't have any funding for it. I think we really need to make good on our commitments. So let's be sure that we have at least some sense of a funding, funding plan to at least get these projects going. So, a little bit more work in the front end, but I think in the long term, it's going to be, it'll be more productive, and I think we'll also be able to have a more consistent message to the community. Thanks.
Thank you, Supervisor. I just wanted to say that I think you've just highlighted one of the big challenges we face in our capital improvement planning process each year, including the 10-year CIP, which, on the one hand is really helpful to lay out what we anticipate will be some major projects to undertake over the next decade, even though the funding obviously isn't yet allocated for some of those out years, and the funding picture in terms of what will be available and how many of those projects we can support is hazy at best. On the other hand, I think you highlight that we do create community expectations around the funding of those projects, and so I think I would just flag that the internal staff conversations have been really challenging around this year's CIP because we don't have funding even for really mission-critical existing capital investments needed to sort of keep the lights on for a lot of our current operations given the funding constraints. And I think that's going to be, as I see it, a really major ongoing challenge for us as we have lots of necessary capital investments needed just really to sustain our current clinics, our current hospital operations, and then also, of course, all the other facilities that support county service delivery. So just want to offer that as some important context as we look at this project, which I think is one that any of us, along with the many other projects to expand healthcare delivery, are really supportive of in concept, just really struggling to figure out how to put the capital needs in the most appropriate priority order as we bring forward recommendations to the board.
Okay, good. We moved and seconded. No further comments. Let's take a vote.
Vice Chairperson Abekoga.
Aye.
And Chairperson Lee.
Aye as well.
Motion
Thank you,
carried.
Jeff. All right, moving on, number 10 is the verbal report from BHSD relating to housing programs.
Great. Thank you, Chair
Dr.
Lee and
Yes.
Supervisor Abekoga. Our Deputy Director, Megan Wheelahan, is here to provide that update. She just walked in the chambers, so we'll just give it a second.
Good morning. We are just upstairs working intently on these programs. So Behavioral Health Services Department provides about $44 million worth of housing services to our clients. And that amount doesn't include the amount we are spending on what we call community residential treatment facilities, which also provide safe and habitable housing for clients in treatment. That $44 million includes transitional housing units for both clients involved in intensive mental health treatment and also justice involved in clients, recovery residences for folks who are involved in substance use treatment services, and our rental assistance program. And master lease housing. The rental assistance program is about $29 million this year of that overall pot of money. And the rental assistance program is funded by behavioral health bridge housing, at least in this last year, Mental Health Service Act funding, and also a small amount from the Department of State Hospitals, kind of reimbursement through a grant that we have. The other housing options that we have are also funded through substance use block grant funds and other smaller kind of grant funds that we receive to serve various populations of folks. Since we last talked to the board, we have had a few convenings with our stakeholders around housing. We had one large convening, the first of, is it 4 or 5? 4 convenings. We're planning before the end of the fiscal year to talk about our rental assistance program and kind of its trajectory, its prioritization, and how it can best serve the clients in our system and ensure kind of overall prioritization of what we want to accomplish with both treatment and housing and behavioral health. We've also kind of met with our justice partners, the court, the Public Defender's Office, the District Attorney's Office, to give them updates on kind of the JAC list and the number of folks we're taking off the JAC list to put into the rental assistance program. I think we've put in the last month or so about 25 clients have been accepted into the rental assistance program. I know our partners who are here today are working hard to find units for those folks and make sure they have a place to go. Yeah, so that's kind of the update. In another couple weeks, we'll have another convening with our partners to look at the rental assistance program, look at some of the data, understand the budget, and kind of make some plans for next year together. Happy to take any questions.
Yeah, good, Greta.
Yeah, I was just going to add, I know because we were just finalizing the materials for the next quarterly report to the board, there's a pretty significant deep dive with a lot of data on this program included in that next quarterly update to the full board. And I know this issue has been of interest to some of your colleagues, so also just wanted to flag that there'll be further data and also discussion of this program and the real growth of clients needing the service and how that's impacted the budget and the planning process going forward, plus how we can prioritize some of the folks who are in the program between the various categories, including those who are justice involved.
Okay, thank you. Clerk, how many speakers do we have on this item?
We have 2 speakers in the room, and we have 1 online.
Let's do 2 minutes each.
All right, we'll have Aaron O'Brien and John Jubanley approach the podium, please. You will have 2 minutes to speak each.
Good morning, Aaron O'Brien. And I'm here today out of deep concern that we are not urgently addressing the current and escalating crisis. As of last Friday, the JAC list stood at 171 clients. The 1 out, 1 in approach may be helping in small increments, but it is not moving people out of jail at the pace that's needed, and we are exhausting the limited resources that we have available. And separate from the crisis faced by those still incarcerated, we're also seeing a serious breakdown in housing support for clients who are in the FSP adult programs. What was once a core element of the intensive treatment programs has vanished. And right now we are using flex funds to purchase tents because the only option left for some of our clients in our intensive treatment programs when they leave residential care is homelessness. And there has been a good long-term planning meeting. But that is not going to help us solve the very real crisis we're in today. And if we're not willing to use either MHSA reserve funds or the prudent reserve or realignment funds to address the crisis that we're in now, then we need to be honest and transparent with ourselves and with the courts and our court partners and plan accordingly. And I understand the fiscal challenges we are facing. I truly, truly do. But let's be clear, if we're choosing not to act, then that too is a decision, and one that has real and immediate consequences for some of the most vulnerable people in our community. Thank you.
Thank you.
Good morning.
Morning,
I'm
Judge.
Judge Manley. I just wanted to ask you and urge you to make this a priority. We simply, in the court, can't go on this way. We talk about a jack list. That's fine. It sounds like something in a budget. But it's real people that are sitting in jail for months because we can't release them. They've been ordered released. There's nowhere to go. And everything came to a halt over this housing issue. Then we were told that it would be prioritized and that we would have an interim solution. We have no interim solution. I want to make sure you understand how committed the court is to working with the county. We have 2 federal grants, and from those 2 grants, we are going to commit 12 beds over 2 years at the Vermont facility and another 10 beds subsequently in the next few months. I think you have to make a decision. The jail, if you look at the population projection report, we are seeing more and more acutely ill people in our jail. Our jail is becoming a mental hospital. It already is. And of those individuals, they gave a number of 900. Nearly half of them are receiving the most intensive services that they would get in a hospital. And I think if you read that report and you look at what controls your jail population, what are the drivers? One of the drivers is not being able to get these people out of jail and into treatment. Therefore, thank you. If you don't take
Actually,
action,
go ahead, Judge. Go ahead and finish.
no, what I want to suggest to all of you is if the board doesn't take action, you are now choosing the jail, funding of the jail over people's lives. Thank you very much.
Thank you, Judge.
And online, we have Paul Soto. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Paul Soto from the Horseshoe. Thank you, Judge Manley, for your analysis and for stating very clearly the issue of a person staying in jail. They're under no sentence. They have been released from jail, but because of the deficits that have been created in times past, that person needs to stay in jail. And it has absolutely 100% nothing to do with them. Now, these are lawsuits just waiting to be filed. That's a class action lawsuit. Because you cannot deprive somebody of life, liberty, or property without just compensation. This is a Fifth Amendment law. You cannot deprive them of their liberty without just compensation if you do deprive them of their liberty. And that's what this is. It's a deprivation of liberty caused by deficits in the THU placements and other placements around within the behavioral health system. It absolutely has to be addressed. Because of that, you can't hold somebody incarcerated. I mean, this Mayor Mahan is literally a sociopath. And I mean that. He is bent on, I want everybody that's homeless arrested. And I'm gonna blame the county for the deficits that the city of San Jose's mayor, both him and Mayor Liccardo, created ever since 2016 and the non-disclosure agreement was signed with Google. The city of San Jose necessarily created the deficits that necessarily prevented people from being housed, and the poverty level has increased exponentially. And he's not man enough to accept responsibility or accountability, so he's busy pointing fingers at you guys and weaponizing the police department.
And that concludes our request to speak.
Thank you. Yes, go ahead, Vice Chair. You have some questions?
Oh, yes, thank you, Chair. I just was hoping to get a response from staff on the comments made by the judge and Ms. O'Brien. And
Maybe I
who
can
wants to-
start,
go ahead.
and then we'll turn it over to Sherry or to Megan. I think, you know, the challenge in this conversation is I think there's actually quite clear alignment of values and limited resources with which to effectuate our shared values. And so I would describe it this way, which is, as Ms. O'Brien stated, historically, we've had the ability to offer for clients in our intensive programs housing resources while they were in those programs. I think there's some policy issues that we are grappling with now that candidly I think probably should have been grappled with earlier around the fact that access to some of those housing resources would fall away once that client got better and didn't need that intensive service anymore, which I think is a big challenge because you know, it is not sustainable for us to house in perpetuity folks who may briefly need intensive treatment and an associated housing resource. I think the other challenge that we face that really is highlighted in Judge Manley's comment is right now we have a structure where in the collaborative courts, there are instances where we have folks who are being held in jail who the courts say can be released as long as they're able to enter a treatment program and housing. But when our housing resources are exhausted, that functionally means that person is being held by the court in our jail because they are unhoused. And that is, I think, an untenable situation as well. But it isn't the case that the county has infinite resources to devote to this without needing to cut other programs and services. I think, you know, this is just a collective, profound challenge that the board is grappling with, that county administration is grappling with every day, that there are more people in this community who need housing resources than the county has available to offer. And as I mentioned previously, we absolutely have been prioritizing providing those resources, and we'll continue to refine the ways that we're doing that to the folks who are in custody. But I do think we need to also stare down whether the current structure where we are holding people in jail, where the court is deciding to hold people in jail until they can be released to these programs, is a tenable one when the housing resources aren't infinite and the number of people who need the housing resources continue to grow. It's just a very challenging situation all around, and I think we all have really strong, appropriate feelings about how challenging it is, but it's also one that's really complicated to solve.
Well, I appreciate that. There's so much need and just never enough resources, and I especially now, and so I appreciate the challenge and the dilemma, and frankly the decision making, the hard decision making that needs to be done, and that's again why we have engaged in this idea of priority setting and so forth, and that's really what I've been trying to talk about. Is we have so many competing needs, but given our limited resources, we do just really have to clarify like what are our priorities, and again be transparent about that. So it's not that we don't everything's a priority, yes, but what are the most immediate priorities? And that's what I hope that we'll be able to engage more in the fall with the board. Thank you.
Yeah, thank you. So this item was heard back on the PSJC meeting, and at the time there was a recommended direction for the stakeholders to actually meet. Did that happen yet, or is this something that's supposed to happen soon?
Yes, we've met a couple times. I think there's still more to discuss, so we certainly have an upcoming meeting the 15th, but also would be happy to meet with a smaller group, including Community Solutions and Gardner, our two providers for the intensive programs for patients coming out of jail before that as well.
Well, clearly the urgency is there. And so I would certainly urge that these stakeholder meeting with a smaller group to take place as soon as possible, and if possible, to at least keep us updated on an ongoing basis, even like say next Tuesday we have a public health crisis report on the board, so if you could bring something back on what this ongoing meeting is. I also heard that there's a large conference with some of our stakeholders, some type of annual conference coming up later this week. Do you know what I'm talking about?
I'm not personally
You know,
attending,
okay,
but I
so-
think
so-
our stakeholders probably are.
Okay, so if that's the case, I would certainly like to make sure that we are engaged in that conference and make sure that if these are issues that we could be brought up and what are the proposed solution we might be able to come up with. Yes, go ahead, Greta.
Yeah, I just, your question made me want to just highlight one thing as a preview of what's going to be in that quarterly report, and I hope many of the stakeholders here today will be present for the presentation on that item, and we'll review it. It really, one of the slides and materials that the department is in the process of finalizing really highlights the growth in number of folks served in these services, and also the major increase in investment the department has made in increasing these services. And we really are, I think as I'm understanding it, just facing a situation where despite significantly increasing our investments, the demand is just outstripping even those increased investments. And so I think that's something that I really hope we can, to your point, make sure there's really clear collective understanding around, because this is not a circumstance where the department and county administration or the board aren't continuously prioritizing deeper and deeper investments in expanding access to behavioral health services, including the housing services that support the clients in these programs. But we still are very pressed with the fact that we're still not able to serve everyone that we'd like to serve. So appreciate you highlighting that upcoming report, and hope that in addition to the stakeholder meetings that I know are planned and have already happened, that there can be also just development of a better shared understanding of some of the investments being made and the number of clients that we're currently serving, because I think that's a critical part that may be not as well understood by some of the folks in the community not involved in the behavioral health department administration.
Sure. It's been said a few times, I don't want to ask you, put you on the spot, but if you could also put in on the report the whether or not MHSA funding could be dipped into to help supplement some of these funding if necessary, yes or no. I think that would be helpful for us to know this is something, a potential solution that many of our community members has mentioned previously. Okay? Yeah. Okay, thanks. Anything else? If not, I've just asked to have a report received.
Yes, I'm happy to make a motion to receive the report.
Okay, I'll go ahead and second that. Let's go take the vote.
Vice Chairperson Abakoga.
Aye.
Chairperson Lee.
Aye as well.
Motion
Thank you very
carries.
much. Okay, great. Thank you. Let's see, moving on to item number 11, which is the recommendations of a verbal update, emerging issues impacting our county's Santa Clara health systems, programs, and services. Actually, Jess, do you see anybody you would like to speak on this item? No. Oh, I mean, Paul, I'm sorry. Paul, go ahead. Sorry about that.
Sure. I'm more than happy to take any questions. You do have our
okay.
written
Yeah, we have the
report.
report. Yeah, we read it, so I just want to make sure we go straight to questions if there's any. Nope.
No request to speak.
Okay, I'll close public comments. Go ahead, Paul. Anything else? Or-
No, sir.
Okay, all right. Moving on, Public Health Officer, Dr., it's funny, my notes still have Dr. Cody, as we know. But yes, Dr. Redmond, good morning.
Thank you, President Lee. Thank you, Vice Chair Abakoga. 3 quick items I do want to highlight on behalf of the Public Health Department. The first is actually good news. I just want to share with you that our public health laboratory is being recognized nationally for a Model Practice Award for its novel surveillance tool of testing raw milk for H5N1 bird flu. And as you've heard and we've shared in this body before, this was a way to make sure that we in Santa Clara County didn't wait for other regulatory bodies to do what we knew was necessary to understand the risk to people here at home, including our dairy workers and folks who may consume raw milk for sale. So I'm very pleased that this is, because it was the first time it was done nationally, and to my knowledge, the only time it's still being done by a local health lab, being recognized at that level. The second is a new threat that we are monitoring closely and working very closely with our vector control district to respond to. And that is the first detection this year in 2025 of the Aedes aegypti mosquito. And this is a mosquito that is not native to Santa Clara County. It's an invasive species that has the capability, when there are other people here who have certain diseases already, of spreading those diseases to our community members. These are potentially life-threatening and very serious diseases like dengue fever, yellow fever, chikungunya, and Zika virus. And these are problems we previously just haven't had to worry about here locally, and now are threats to our community members if we don't act very quickly to respond to this threat of this new invasive mosquito. And so our vector control district is out with their mosquito experts in the neighborhoods around these detections, working hard, helping people in their backyards do the kind of trapping, testing, and removal of mosquitoes. But we do need everyone in the community to help respond to this threat in 3 specific ways. The first is to call the vector control district if they have bites from mosquitoes during daytime, because the normal mosquitoes who live here should not be biting us during daytime hours. The second is to dump out standing water in your yard, in your property. These mosquitoes can breed in just a bottle cap worth of standing water. So everywhere in your yard, you may have a bird bath, an old bucket left outside. Dumping that out, cleaning that out is going to be important. And then finally, allowing the mosquito experts, if they come to your neighborhood, to do their job and keep us safe from this invasive species. And then I think my last update for the body here is just that I think I'd be remiss if I didn't comment that the greatest threat to public health in Santa Clara County is exactly the topics we've been discussing today, presented by Mr. Margol and Ms. Carta, described by Mr. Williams with respect to the threats to Medicaid and what that means for the Santa Clara County safety net system and the health systems we all rely on. And in the public health department, we're also experiencing these imminent risks to our budget, and so look forward to what we see tomorrow in the recommended budget to help us address that immediate risk. But I just want to offer my thanks to the county executive, to our Office of Budget Affairs, who've been working incredibly hard to figure out how we meet this imminent risk to sustaining public health services and access in Santa Clara County. And I want to thank the staff of the Public Health Department, who I think listen to the radio every morning and hear some new threat to their immediate work, and they show up every day and work incredibly hard to protect the safety of people in Santa Clara County. And I'm happy to take any questions. Thank you.
Thank you. I don't have any questions, any? Nope. All right, good. Dr. Terrell?
Hi, good afternoon. You have our written report. The only addition I wanted to add was, as you recall, the state authorized us to reopen submitting denied claims dating back to July 1st of 2023. And so we opened several windows to our CCPs to be able to resubmit denied claims during that period of time. And we wanted to acknowledge the work of our contract providers. So to date, they've resubmitted about 10,000 claims.
Wow.
So
Great.
just wanted to acknowledge the hard work there and just really appreciate the partnership in, trying to recoup some of that revenue from that time.
Thank you, Dr.
Thank
Terrell. Yes, Laura, on VHP.
Thank you so much, President Lee and Co-Chair ALCOVE. You have our report. I'm happy to answer any questions.
Okay, I don't have any. Okay, good, very good. All right, let's see, I think that's about it. Is there a motion to receive the report, please, Vice Chair?
Motion to receive the report.
Did we have public comment?
Oh, I'm sorry. I believe we did earlier.
We opened and closed the public comment period. Since that period, a member of the public has requested to speak.
Exactly. All right, let's go and go to take the vote. Got a motion and seconded. Yes.
Vice Chairperson Abekoga.
Aye.
Chairperson Lee.
Aye as well. Thank you.
Motion carries.
Well, before we adjourn, I just want to mention today being April 30th is the 50th anniversary of the Black April Day, when the fall of Saigon, which ended the Vietnam War. And of course, we still remember those who perished and those who are still missing in action. I just want to make a quick comment to commemorate that important day. And with that, our meeting is now adjourned. Our next HXC meeting is now scheduled for Friday, May 23rd at 10 a.m. right here in Board Supervisors Chambers. Thank you. Thank you.